welcome everyone. It's lovely to have you with us for the first of our new clinical series. My name's Anna. For those of you who don't know me, I'm the Head of Support Services at Overcome. So it's just to let you know that we are available for support and information Monday to Friday, 10 AM to 5 PM. Please do get in touch with us. There's myself and my colleagues Annie and Catherine, and we're always really happy to talk anything through. You can get in touch with us on our support line, email us, text message, instant chat through the website. We can set up a video call. We also have a variety of support groups available, and also our online forum, and all of those details are on our website. So anything at all, please do contact us, and we'll look forward to hearing from you. And I'm delighted to welcome Dr Terri McVeigh, consultant clinical geneticist at the Royal Marsden, who's going to talk to us this afternoon about genetic testing in ovarian cancer.
Great, thanks a million, Anna, and thanks indeed to Overcome for inviting me to speak today on a topic I'm very passionate about. And actually, this is very timely because I'm not sure if people are aware, but the guidelines around genetic testing within the NHS have literally just been updated within kind of the last 3 weeks. So this is hot off the press kind of information. So hopefully people will find it beneficial today. I will say from the outset, as Anna mentioned, I'm a clinical geneticist, not an oncologist. So the focus of today is very much about genetic testing with a focus on hereditary risk factors for ovarian cancer, but we will touch on some of the implications for genetic or some of the implications for treatment associated with these genetic test results. So hopefully you can all see my screen. So the outline for today, we're going to talk a little bit about genetic risk factors and genetic drivers of ovarian cancer and explain what the difference between those two concepts are. We're going to describe the risks that are associated with inherited genetic risk factors, focusing predominantly on BRCA1 and BRCA2 because they're two of the genes most commonly implicated in ovarian cancer risk. We're going to talk a little bit about how genetic risk factors are inherited. As I mentioned, we'll talk a little bit about the implications of genetic test results for treatment and describe what unaffected carriers of inherited genetic alterations can do to manage their risk, particularly the risk of ovarian cancer, because obviously that's our focus today. And then I'll go briefly through the NHS guidelines for genetic testing based on the new criteria. So hopefully all of you will be familiar with the female gynecological tract, but actually it's amazing how kind of mysterious this can be to some people, and there's a lot of misunderstanding about where exactly all the bits and pieces are. So essentially your ovaries are here, these little kind of structures that are sort of interconnected to, well, not directly, but they're very close to the fallopian tubes, and the egg every month gets released into the fallopian tube down into the uterus. The neck of the womb here, sorry, the uterus is also called the womb. The neck of the womb is your cervix, and that's your vagina. And actually it's interesting because what we call ovarian cancer, there's new evidence to suggest that actually a lot of that starts in the fallopian tube. And because the fallopian tube has this direct access to the ovary, any cancerous changes in the fallopian tube can spread very easily to the ovary. So what we're calling ovarian cancer, actually a lot of it is really fallopian tube cancer that happens to involve the ovarian tissue. There's also another organ that lines the inside of the abdomen called the peritoneum. And again, fallopian tube directly connects out into the peritoneum. So you can get cancer of the peritoneum, which is called primary peritoneal cancer. And again, there's a thinking that actually a lot of that is cancer that started in the fallopian tube. So what we call ovarian cancer is sort of an umbrella term for cancer affecting the ovary, potentially the fallopian tube, and the peritoneum as well. So when I say ovarian cancer, I'm really talking about all of those types of cancers depending on the context. The average risk in the general population, so people that, as far as we know, don't carry any particularly high risk genetic trait, about 1 in 70 among people that have ovaries. So not terribly rare, but not terribly common either. There are a number of different risk factors for any type of cancer, obviously, but when we focus on the risk factors for ovarian cancer, one of the main risk factors is getting older, which none of us can avoid, unfortunately. Other risk factors that are potentially modifiable are things like being overweight. So if you can address being overweight, you can hopefully reduce your risk. There are certain hormonal and reproductive risk factors. So for example, not having children increases your risk. We know there are lifestyle and environmental factors, and there's some evidence for things like smoking and exposure to different chemicals. But really, factors that can't be changed and you can't do anything about include your family history and certain genetic risk factors. And that's what we're going to focus on today, obviously. So hopefully a lot of you will be familiar with the notion of genetics and genomics, but I keep it very, very simple for myself to avoid getting really confused. So I always think about your genetic information. It's like the instruction booklet that controls how your body grows and develops. We inherit our genetic information from our parents. We get about half of it from our mom and half of it from our dad. And when we talk about genes, what we're talking about are basically words in that instruction booklet. And when we talk about genetic alterations or genetic changes, what we mean is a spelling mistake in one of those words in this booklet. And some of those genetic changes are more harmful than others. So if it happens in a very critical part of that instruction manual, obviously that has a bigger impact. So when I talk about the genetics of cancer, it gets a little bit confusing because actually all cancers have genetic changes. Cancer always starts from a cell that was once normal. And over time, genetic changes happen in those cells. And if genetic changes aren't corrected, that cell becomes increasingly abnormal, and that's what causes cancer to happen. So let's pretend for a second, this is the normal cell. Over time, even if you weren't born with any genetic alterations, that cell, every time it copies over, it's quite an error-prone process. So nature is, in a silly way, did not make us kind of mistake-proof. So every time a cell copies over, it has the potential for acquiring these little blips. And if that's not corrected by certain what we call DNA repair mechanisms, uncorrected, those cells become more and more dodgy over time and eventually become cancerous. So we've fortunately got a lot of DNA repair mechanisms that can come in and correct that damage, and that's what prevents cancer. But obviously, if something goes wrong in that DNA repair pathway, the risk of cancer starts to increase very dramatically. Some people are born with inherited problems in these DNA repair pathways, and those people are much more likely to develop cancer because any of those mistakes that are really common go uncorrected, and that's what leads to the development of cancer down the line. The different types of genetic changes that contribute to ovarian cancer risk really depend on the subtype of ovarian cancer. So when we talk about different subtypes, what we mean by that is how they look under the microscope. So when we take a sample of an ovarian cancer, we look at it under the microscope. Well, I don't, the very clever pathologists do, but we look at it under the microscope, and depending on what it looks like, we can categorize it into different categories. And the nice thing about genetics is that actually when we do genetic profiling on the ovarian cancer, the genetic changes very much match what we see under the microscope. So me, even though I'm not a pathologist, I can kind of guess what the ovarian cancer cell will look like under the microscope, depending on what genetic changes I see occurring within the cancer cell. Some of these genetic changes will only ever happen by chance as the cancer cell was developing, and they're not considered hereditary risk factors and won't have implications for any other members of the family. But some of the genetic alterations that happen can happen either by chance as the cancer was developing, or can be inherited and passed from one generation to the other. And I've underlined there in red some of the genetic changes that can happen in either situation. And the difficulty for us, if we do genetic testing on a cancer cell and we find a genetic alteration, for example, in BRCA1 or BRCA2, all you know is that the alteration is there. You don't know when it happened. So you don't know if it happened as the cancer cell was developing or whether it was there all along from the minute that woman was conceived. And in that situation, we may need to do further testing to try and figure out whether it is a hereditary issue or not. So the way that we can figure out if it's a hereditary issue or not is by testing the blood cells as well as the tumor cells, because blood cells are kind of a representative of the normal cells in the body. So this is another example of this. So on the left-hand side of the screen, on my left-hand side of the screen there, this particular patient has been found to have a genetic alteration in her ovarian cancer specimen, but she's also been found to have the same alteration in a sample of her blood. So this genetic alteration is a heritable one. It's likely been inherited from one of her parents, and she can pass it on to her children. The woman on the right-hand side, in contrast, has been found to have a genetic alteration in her cancer cell, but that alteration was not present in her blood sample. So what that means is we can assume, for the most part, that that alteration has happened by chance as that cell was, going from this normal situation to becoming a cancer. So it was acquired over time completely spontaneously. And in that situation, the children and other relatives in this family will not be considered to be at risk of inheriting this. So it's really important that we distinguish between those two, because obviously there's bigger implications for the family members if it's a hereditary event. So when we talk about the repair pathway, so I mentioned there that this kind of cell damage that happens over time can be corrected by certain repair pathways. The names of them sound very intimidating, and don't worry too much about it. The reason I'm mentioning it here is because you will see it depending on what type of testing you're offered. So most of the genes that we know are associated with ovarian cancer risk fall into two of these repair pathways. There are multiple. I'm not going to bamboozle you with all of the different pathways. We're going to focus today on two pathways called homologous recombination repair and mismatch repair. You don't really need to know the science behind it, other than they correct slightly different types of cell damage. Genes that are really important in the homologous recombination repair pathway include genes like BRCA1 and BRCA2, but also some other genes that you may not be as familiar with because we've only started testing for them very recently. And they include things like PALB2, RAD51C, RAD51D, and BRIP1. And I'll talk a little bit more about them later on. Another repair pathway that is important, but probably less commonly implicated in ovarian cancer, is a pathway called mismatch repair. And there's a number of different genes involved in that pathway as well. The names, just for your kind of interest, are MLH1, MSH2, and MSH6. There are other genes involved in that pathway, but they're not so relevant to ovarian cancer risk. So we're really going to focus on those three genes today. The reason I'm mentioning these pathways in particular when it comes to the ovarian cancer situation is because cancers that are related to problems in the homologous recombination pathway are much more likely to respond to certain types of chemotherapy. So in the ovarian cancer setting, the type of chemo that we're very much of interest in this particular pathway, platinum-based agents. So the kind of platinum-based chemotherapies we talk about, carboplatin, cisplatin, a number of you that have had treatment will be familiar with these types of chemo. The other drugs that the other class of drug that we're really interested in are PARP inhibitors, and I'll explain a little bit how those drugs work later on. Interestingly, cancers that are due to problems in the other repair pathway that I've mentioned here, mismatch repair, they're less likely to respond to those kind of chemotherapies and PARP inhibitors, but they're more likely to respond to another class of drug known as an immunotherapy. So it's really, really crucial that we figure out what exactly is the genetic basis of your ovarian cancer, regardless of what it looks like under the microscope. We need to know what's happening at a molecular level, because that's really going to determine what treatment we recommend. So hopefully a lot of you will have heard about PARP inhibitors, and I'll just explain how they work. So let's think about our normal cell again for a second. So that normal cell, as I mentioned, every time that copies over, it's very prone to developing errors. Okay, we know that's very natural, normal, that happens every time a cell copies over. But most of the time, our homologous recombination repair pathway and other pathways, including where PARP works, fix those errors, and the cell goes back to normal, and we go happily about our business without cancer. If that normal cell that acquires the genetic change happens in somebody that has a dodgy homologous recombination repair pathway, because they've got an inherited BRCA1 or BRCA2 alteration, or because of some spontaneous event, what happens is your single strand repair pathway, so where PARP works, might still be working. So some types of cell damage might be corrected, but the other types of cell damage that are usually repaired by homologous recombination repair don't get corrected. And what happens then is that cell does become dodgy and ultimately becomes cancerous. If that kind of PARP repair pathway is still working, that's actually bad news for us, because it repairs enough of the damage for the cancer cell to keep going. And what we have come to realize is that if you block that PARP repair pathway as well, what happens is the combination of the different types of damage is actually too much for the cancer cell to survive, and it becomes increasingly unstable and then just kind of melts away. Well, that's what we hope will happen. But that's really how PARP inhibitors work. It kind of it removes that kind of secondary pathway that cancer cells use to repair some of their damage. And if we can block that, the hope is that that will target the cancer cell but leave the normal cells alone. And the reason this is so of interest is because a very significant proportion of ovarian cancer will demonstrate this kind of problem in the homologous recombination repair pathway, so over 40%. And some of that will be due to inherited risk factors in the genes involved in those pathways, and some of it will be related to problems in those genes that have happened by chance as the cancer was developing. So what does all of that mean? So it means now that currently in the NHS, as of April 2022, we now recommend that all ovarian cancer cells, so a sample of the ovarian cancer tissue, is sampled to check for genetic problems, particularly alterations in BRCA1 and BRCA2, and for features of this faulty homologous recombination repair pathway. And the type of ovarian cancer that we recommend we do that testing in is the high-grade serous type, because that's the one that's much more likely to be related to problems in this particular pathway. The checking for these features, because it has such big implications for PARP inhibitor treatment, the people that we really offer this testing for are people that will potentially be considered for that type of treatment. If we focus on the hereditary risk factors for ovarian cancer for a second, a number of genetic risk factors for ovarian cancer have been identified. These can be broken down sort of artificially into three categories: high risk, and the high risk genetic risk factors are those that are associated with at least a 10% lifetime risk of ovarian cancer. So you're talking, nearly 10 times greater than the background population level risk. Moderate risk genetic risk factors are those associated with between a 5 and a 10% lifetime risk of ovarian cancer. And low risk genetic risk factors are those that are associated with a less than 5% lifetime risk of ovarian cancer. The reason I say they're sort of artificial is because I don't know how comfortable I would be if I was told my risk was 9% compared to 10%. So it's becoming really controversial as to whether we should manage moderate and high risk any differently. The low risk genetic risk factors are really interesting because most of them, when I say less than 5%, actually most of them individually are only associated with a very slight increase in the risk of ovarian cancer. But what we're coming to realize is that actually, if you have a combination of those low risk factors, so if you have 10, 20, 30, 40 of those low risk factors, actually your risk overall might start to approach that of someone that has a moderate or a high risk genetic risk factor. So testing for low risk genetic risk factors is not currently available in the clinic, and that's more to do with the fact that we're not really sure how to interpret them or how to manage them than anything to do with cost. But I really anticipate that we will probably be testing for those low risk factors down the line to give a bit more of a comprehensive overview of an individual's risk. At the minute, the testing in the NHS until April was really restricted to the highest risk genetic risk factors. But as of April 2022, we now will offer testing to people with certain types of ovarian cancer for genes that fall into the high and moderate risk category. And as you can see from, as you can see from this image here, those high and moderate risk genes are the ones that we've been harping on about that work in the homologous recombination repair pathway and the mismatch repair gene pathway. So BRCA1, BRCA2, RAD51C, RAD51D, PALB2, MLH1, MSH2, MSH6, and I've actually dropped BRCA1 off that graph. It should be there. Sorry, that was my mistake. So they're the genes that we now offer testing for on the NHS. So the guidelines, as I've mentioned, have changed, and they've changed for the better because now we can offer testing more broadly and we can offer testing of more genes. So currently, NHS guidelines recommend that people with ovarian cancer have testing for hereditary risk factors in those genes that I've mentioned there if they have high-grade non-mucinous ovarian cancer. So the non-mucinous basically includes anything that's categorized as serous, endometrial, and clear cell. And if you have ovarian cancer and you're not sure what type you have, ask your oncologist because they should be able to tell you that pretty easily. The other people that we recommend testing for are women that have a history of ovarian cancer, but maybe not of those subtypes, that also have a family history of ovarian cancer, or other genes that we know can share a genetic risk. So things like breast cancer, prostate cancer, and pancreatic cancer. So certainly if you have ovarian cancer and you've got a family history of any of those type of cancers, do ask your oncologist if you're eligible for testing now. And as I mentioned, the genes that we're offering testing for: BRCA1, BRCA2, BRIP1, RAD51C, RAD51D, MLH1, MSH2, and MSH6, and PALB2. So I'm going to focus for a minute on BRCA1 and BRCA2. And the reason for that is, of those genes, these are the ones that are most commonly implicated in familial ovarian cancer. So they deserve a bit of attention in their own right. People that have cancers related to alterations in either of these genes are also the ones that are most likely to benefit from PARP inhibitor treatment, even compared to other genes in that homologous recombination repair pathway. So these genes, you might hear them called tumour suppressor genes, and they can be called BRCA1 and BRCA2 as well as BRCA1 and BRCA2. The names don't really matter. It's just in this part of the world, we tend to call them BRCA1 and BRCA2, and in America, they tend to spell them out for some reason. So I don't know, you may hear them used interchangeably. Don't get worried, it's the same thing. They work essentially to prevent the development of cancer by correcting certain types of cell damage, like we've talked about earlier. And if somebody carries an alteration, so a spelling mistake in one of these genes, that interferes with that DNA repair process, and that leads to increased cancer risk. You'll notice so far I haven't used the word mutation. It's a word that brings me out in hives because it makes me think of X-Men and Spider-Man and all of that kind of stuff. And we tend not to use it anymore. But when I say alteration, you may have previously heard the word mutation used there as well. And some people still do. It's just a personal, I don't particularly like the word, so I tend not to use it. So the types of cancers that we see in people that inherit problems in BRCA1 or BRCA2, the big ones are certainly breast and ovarian cancer, with the addition of prostate cancer in people who have prostates. And there's also significantly increased risks, but low overall, in terms of pancreatic cancer. There's new evidence to suggest there's also an increased risk of stomach cancer and possibly an increased risk of melanoma type skin cancer. To give you an idea of what the risks are, have a look at this table. And I think it's always important to remember how frequently these cancers occur in the general population anyway, because a lot of these cancers are not all that rare, even if you don't carry an alteration in BRCA1 or BRCA2. So when we talk about breast cancer in biological women, the average woman has a risk of about 1 in 8 anyway, which is about 12.5%. If you carry a BRCA1 alteration, that risk goes up really significantly, and the lifetime risk overall is between 65 and 79%. So that's the chance of getting breast cancer over your lifetime. BRCA2 carriers have a risk that's very similar, between 61 and 77%. People forget that biological males also have breast tissue in their chest wall, so there is an increased risk of cancer of that tissue too. Overall, it's not huge when you compare it to the risk in biological women, but it can be increased quite significantly, particularly in men that carry BRCA2 alterations. The one that we're all particularly interested in today is the risk of cancer of the ovary and fallopian tube. And you can see, I mentioned here, the average person has a risk of about 1 in 70. If you carry a BRCA1 alteration, the risk is anywhere between 36 and 53% over your lifetime. And if you carry an alteration in BRCA2, the risk is between 11 and 25%. And you can see the risks of other kind of cancers are increased compared to the general population, but low overall when you compare them to the risks of breast and ovarian cancer. The reason I give such broad ranges, so I know people get really frustrated when they're like, well, is it 36 or is it 53? Like, where do I fall on that kind of range? And the reason it's so difficult to give very specific risks is when I talk about spelling mistakes in a gene, these genes are tens of thousands of letters long. So you could have any, there's thousands of potential spelling mistakes. So trying to give specific risks for your specific spelling mistake is really difficult. So what we've done is we've kind of gathered information and averaged it out across the different spelling mistakes. We do know that the differences exist between BRCA1 and BRCA2, as well as between the different spelling mistakes within the genes. We also know it depends on what age you are. So the risk to a woman that's only 25 is very different to the risks that we will give a woman of 45. It also depends on your gender. So if you're biological male or biologically female, It also depends on whether you're transgender. So we know that transgender individuals will have very different risks compared to cisgender individuals, and those need to be taken into consideration as well. We also need to consider lifestyle and environmental factors, because the same lifestyle factors that influence the risk of ovarian cancer in the general population will also influence the risk of ovarian cancer in somebody that carries a genetic risk. Family history can also influence things as well. So it's really interesting when we have two different families that are unrelated, even if they carry the same spelling mistake in the same gene, you might see different family histories. You know, one family might have loads of ovarian cancer and the other family might have very, very little. So it's really tricky to individualize risks. And we do try our best, but when you look up the risks, you will always just see these ranges given, because it's very tricky to do it without meeting you in person. When I talk about the risk associated with increasing age, this is sort of what I mean. So if you look at the risk of somebody at the age of 25 of developing ovarian cancer, even if they carry an alteration in BRCA1, their risk is very close to the background population level risk. Similarly for somebody with the BRCA2 alteration. That's why we don't go in whipping out women's ovaries at the age of 20, because actually their risk before the age of 35 is very, very slow, very, very, very low. We do want to intervene around the age of 35 onwards, because that's when the risk really starts to ramp up quite significantly. And if you're not found to have a BRCA1 or BRCA2 alteration until you're in your 50s, the first thing that people will do, if you haven't been affected by ovarian cancer, is talk about taking out your ovaries to minimize your risk of developing that type of cancer, because at the age of 50, your risk is very significant. The risk is definitely modified by your family history. So these lines don't look like they're very impressive, but if, for example, you have two relatives affected by ovarian cancer, your risk is going to be higher than somebody that only has one person affected by ovarian cancer. And that's true the more relatives you have that are affected by ovarian cancer in your family. And that applies for BRCA1 and for BRCA2, but it also applies to people who don't have an identified genetic risk factor. So if you have, you know, all the genetic testing that's available and you aren't found to carry a particular genetic risk factor, if you have a very high risk family history, excuse me, you may still be advised to have risk reducing surgery or, you know, other kind of surveillance approaches depending on the context. Excuse me. The age thing is really important when we think about children, because I know people that have very young families are often really worried about their kids in the first instance. And the kind of silver lining with BRCA1 and BRCA2 alterations is, as far as we know, there isn't an increased risk in childhood or teenage years. So we tend not to test kids for these alterations until they're able to give informed consent themselves as adults. So I say adults, but obviously in the UK, we're allowed to test from the time they have kind of the ability to make that decision for themselves. But really the risk before the age of 25 is so small that there's very little benefit to testing them, because you're not going to do anything before that age, and actually it might cause very significant psychological harm. So that's the reason we don't test children. This table looks very confusing. Don't worry, I don't expect you to read all of it. This is just to demonstrate the kind of lifestyle and environmental factors that we consider when we're talking about trying to personalize somebody's risk. You can see there's very predictable things there, things like alcohol use, smoking, being exposed to x-rays, etc., your weight. The one I wanted to focus in on is the oral contraceptive. So GPs in particular get very nervous when I talk about prescribing the contraceptive pill to people that carry alterations in BRCA1 or BRCA2, and that's because of advice from the college, their guidelines with respect to contraceptive use. There is some evidence to suggest that if you use the combined version of the contraceptive pill, so a pill that includes both estrogen and progesterone, there's some evidence to suggest that that might increase your risk of breast cancer if you carry an alteration in one of these genes. Your risk of breast cancer when you carry one of these genes is so high that the risk associated with this, you know, it's incremental. There's also evidence to suggest that actually if you take the combined oral contraceptive pill for 4 years or more, you actually can reduce your risk of ovarian cancer very significantly. So it's like everything, it's kind of a risk-benefit analysis. So you kind of need to decide for yourself, Am I willing to accept this incremental risk of breast cancer and potentially reduce my risk of ovarian cancer? You know, it's up to you. We need to take a step back and look at why you're potentially considering the contraceptive pill. Are there other reasons you're taking it? And look at the alternative options. So what I sometimes say to unaffected women is, look, if, you know, I'm weighing up the pros and cons, I think this is not a complete contraindication to taking it. But if you use it for 4 years, you've already got as much benefit as you're going to get in terms of reducing your risk of ovarian cancer. And after that, all you're going to do is potentially increase your risk of breast cancer. So sometimes women will take it for the 4-year period and then switch to a non-hormonal alternative because they're thought to be safer. At the minute, we don't recommend taking it just for ovarian cancer risk reduction, but certainly we consider your history of contraceptive use when we're kind of estimating what your lifetime risk of ovarian cancer is if you're unaffected. So if we find a hereditary risk factor for cancer in somebody with ovarian cancer, it has implications for their own cancer treatment. It has implications for their risk of developing other types of cancer, and it potentially will have implications for their family planning. Now, obviously, for some women that have had ovarian cancer, family planning decisions are taken out of their hands. Sometimes people have already finished their family before the time they're diagnosed. For their relatives, the implications are they're now at risk of inheriting a genetic risk factor for ovarian cancer. They may themselves be at risk of ovarian and other cancers, and it may also have implications for their own family planning. So it's interesting because this potential test might not just have implications for you, but also for your children, for your siblings, for the whole family. And if you're someone like me from an Irish family, that might have implications for 60 or 70 people, you know, so it's important that we don't miss these things. So let's talk about how these alterations are inherited. So for the most part, we've got 2 copies of every gene because we inherit 1 copy from our mom and 1 copy from our dad. There are certain genes where we only have 1 copy, but BRCA1 and BRCA2, we have 2 copies of each of those. So let's take, for example, here, in this case, dad carries an alteration in BRCA1. When he has a child, he doesn't know which copy he's giving away. Is he giving the copy with the alteration or the copy without? So one child gets this copy from dad, this copy from mum, this copy from mum, and this copy from dad. And this poor girl, because she's inherited the copy of her dad's BRCA1 gene that has the alteration, she's now at increased risk of cancer over her lifetime. So every child of a parent that carries an inherited risk factor in BRCA1 or BRCA2 has a 50-50 or 1 in 2 chance of inheriting that alteration. And that's the same whether you're a boy or a girl. Okay, so and people often forget this, and when I say people, I mean doctors as well as patients. They sometimes forget that men can carry these alterations and men can pass them on. So it's really important that men are not forgotten about in these families. When we think about cancer prevention, it becomes very tricky, and I'm going to focus a little bit on ovarian cancer now because obviously this is the focus of the talk. So if we think about the unaffected individual that's inherited an alteration in one of these genes, people often ask me about the smear test. And unfortunately, your smear test looks for changes in the cervix, which is the neck of the womb. That's quite far away from your ovaries. So the likelihood of picking anything up, very small. So really, it can only detect abnormalities in the cells of the cervix. So the smear test, although we recommend you keep it up because obviously it's important for your cervical cancer risk management, not really going to help us for your ovarian cancer detection. The difficulty with scans is that scans can be normal in the early stages, and it may be very difficult to differentiate between benign cysts and cancers. We have looked a lot at a blood biomarker called CA125, and anyone that has had ovarian cancer will know that we're obsessed with CA125 in that setting because most women who have ovarian cancer, their blood levels of this protein called CA125 will be increased. So it's really useful marker for tracking if their cancer is responding to chemotherapy or not. But it can be increased for other reasons apart from ovarian cancer, including benign gynecological problems. So if you know you've got an increased risk of ovarian cancer and you're told you have an increased CA125, that can cause massive distress. And actually it may end up not being anything cancerous. So that can potentially cause harm. The other risk is that it can be completely normal in women, even if they do have ovarian cancer. So that can be falsely reassuring. There has been a lot of work looking on, could we potentially use CA125 in some ways? So this score called the risk of ovarian cancer algorithm was developed looking at age, menopausal status, your CA125 level, and serial blood measurements over time. I won't go into the nitty-gritty of this study, but essentially this study that was run back in 2017 looked at over 4,000 women screened with this CA125 blood marker and scans. And what they found was that of those people that had this type of screening, 199 people ended up having surgery, and of those 149 did not have cancer. So that's a lot of operations considering they're not for cancer. There were 19 cancers diagnosed in people within the first year of this screening program, but of those, over a third were stage 3B or 4. And really, for a screening program to be effective, we want the cancers that are detected to be stage 1 or stage 0, preferably. So the conclusion from this study was, okay, we could detect cancers slightly earlier, but actually we're not sure if that actually changed their outcome overall. So really we need to do further research to figure out if it's safe to use this. So at the minute, the only proven way to minimize the risk of ovarian cancer in somebody that carries a high risk genetic risk factor is to have surgery to remove the fallopian tubes and the ovaries. The risk of cancer of the womb isn't thought to be increased in people that carry these particular genetic risk factors, so we usually don't recommend removing the womb unless there's another reason that it should be removed. It's a much simpler operation to do without taking the womb, which is why we tend to leave it where it is if it's not causing any bother. Surgery can usually be done by day case, and it's usually by keyhole. Obviously, there's pros and cons to this, like there is with everything. So the huge advantage to having risk reducing ovarian surgery is that it dramatically reduces the risk of ovarian cancer, and it reduces it by over 95%. The reason it can't remove it completely is because of that internal organ that I talked about at the start of the talk, the peritoneum, that is very closely related to the fallopian tubes and the ovary. You can't remove your peritoneum because it's literally kind of all over your abdomen, and it would cause serious problems if you took that out. So there is a tiny residual risk of developing cancer in the peritoneum. That risk is higher if you're found to have precancerous changes in your fallopian tubes. But the risk overall is thought to be very small. There's some evidence to suggest that if you have your ovaries taken out before your menopause, it may reduce your risk of breast cancer. That data is a little bit messy, so we don't recommend it just for that reason, but certainly it's by far and away the most powerful thing you can do to reduce your risk of cancer overall if you carry an alteration in one of these genes. Obviously, the disadvantages, natural fertility is disrupted. It throws you immediately into the menopause. There's always a bit of a worry about HRT in people that have an increased risk of breast cancer, but actually in this situation, if you're having risk reducing surgery before your menopause, the evidence suggests that HRT is safe to use up until the time you would have had your natural menopause. The reason that we recommend HRT is because, as well as the side effects of natural menopause or premature menopause, there's also increased risk of other health problems, so things like heart disease, potentially dementia, bone density problems as well. So HRT we actually proactively recommend unless you've already had a breast cancer, in which case it's not thought to be as safe. Because of the health risks associated with this surgery, we tend not to recommend it before the age of 35, and actually we try to push it out closer to 40 unless there's a very strong family history of ovarian cancer. The Protector study, just to mention this study briefly, so there's a really interesting study being run across the UK now where they're looking at whether you can do this surgery in a two-staged approach, because like I mentioned at the start of the talk, we think a lot of the ovarian cancer that we talk about actually starts in the fallopian tube. And the thinking behind this study is, can we remove the fallopian tubes first, and leave the ovaries where they are, so you don't throw the woman immediately into a menopause. Hopefully you reduce her risk of cancer very significantly, and then you go back later and take the ovaries when she doesn't need them after the menopause. So we're really interested to see how that study pans out, and certainly we're hoping that it will have a beneficial impact in terms of reducing the consequences of an early menopause, and also hopefully having the same kind of risk reduction in terms of the cancer risk, but that's still ongoing. Breast cancer management is a little bit different because we do have very good screening, which is fantastic. So we can offer women the option of either having screening on a lifelong basis or risk reducing breast surgery with the double mastectomy and reconstruction. Screening typically starts from the age of 30, may be recommended from the age of 25 in people that have a very high risk family history. The risk reducing breast surgery decision is really personal, and it's very hard to predict who will opt for this. The reason it's so kind of tricky in terms of making the decision is actually when you look at overall survival. So, you know, are you more likely to be alive at the age of 80 if you have risk-reducing breast surgery compared to having breast screening? There's very little difference, particularly if you've already had a cancer. So that decision can be influenced by your own cancer history, your age, family history, obviously your own relationship with your body, you know, psychosocial considerations, etc. So it's really up to you, and that's one of the decisions I very much leave up to the person in front of me. I you know, can give all the information, but I really leave that decision up to her or you know, the person with breasts. There's always a bit of controversy as to whether we should be recommending risk-reducing breast surgery after a diagnosis of ovarian cancer. And this is based on, you know, certainly before PARP inhibitors came into practice, where, you know, ovarian cancer was very different and people weren't living as long after a diagnosis of that type. So for ages, we wouldn't consider doing breast risk-reducing surgery in somebody with ovarian cancer. We've changed our approach a little bit since survival has improved so dramatically. So now we really consider what age the patient is, what stage their cancer was diagnosed at, and how long they've had disease-free since their original diagnosis. So certainly if you were diagnosed very early, like early stage, and if you were very young, and if you've been disease-free for quite a while, we would consider it now, whereas we wouldn't have 10 years ago. So there's not much research about this yet. I suspect there will be now that we've had quite a long time since PARP inhibitors have been on the scene. So watch this space. But if you're somebody that has had ovarian cancer long ago and you carry an alteration in one of these genes, it's not unreasonable to ask if something like that would be recommended. I'm not going to focus too much on prostate cancer because obviously the focus of today's talk is about ovarian cancer, but there's huge issues in terms of screening here because we have the same problems with the markers for prostate cancer that we do with CA125. So really the jury is out. We certainly recommend it in men that carry BRCA2 alterations because their risk is higher than in men with BRCA1, but research is ongoing. And for men with male breast cancer, we just recommend symptom awareness. Other cancers, pancreatic cancer, screening is not particularly useful. We recommend symptom awareness and definitely avoid smoking. Smoking is pretty toxic to the pancreas. In terms of other genes, the new genes on the block include RAD51C and RAD51D. The risks associated with these genes are somewhat overlapping with BRCA1 and BRCA2, but not as high risk. So the risks that we see, definitely ovarian cancer, definitely breast cancer, and you can see the risks of ovarian cancer in somebody without a family history are in and around 11%. If you have a family history, it starts to increase very dramatically, the same way that we've seen with BRCA1 and BRCA2 carriers. The risk of breast cancer is about 20%. Again, that's influenced by your family history as well. So that's just a graph that demonstrates how the risk is changed by your family history. In terms of how we manage the risk in people that carry these gene alterations, again, the only proven way to minimize the risk of ovarian cancer is to have them whipped out. Breast cancer risk reduction really depends on the family history, so we're a bit less enthusiastic about doing risk-reducing surgery in this kind of context. The tricky thing in this situation is because these genes aren't necessarily very high risk, if you have somebody that has a very high risk family history, we may still recommend that the non-carriers, so people who haven't inherited that genetic risk factor, they may still need management because we can't be completely sure that we've addressed the whole question. So often we may recommend other testing. We're just a bit more conservative about discharging those people. BRCA1 is a really interesting gene. It appears to be limited just to ovarian cancer risk. The good news about this gene is that it doesn't appear to be associated with an increased risk at very young ages. The average age of diagnosis in somebody with a BRCA1 alteration is about 68, which means that when we're talking about risk-reducing ovarian surgery, we can very safely wait until they're kind of closer to the menopause. And there doesn't appear to be an increased risk of breast cancer, so they don't need breast cancer management. PALB2 is a very interesting gene. The risks here overlap with BRCA1 and BRCA2, but the risk of ovarian cancer is not as high unless you have a very strong family history. So in somebody without a family history, the risk can be as low as 2%, which is very close to the population level risk. But in someone with a family history, it starts to approach that of the higher risk genes. So really the risk management in somebody that carries a PALB2 alteration has to be bespoke, depending on what your individualized risk is. So this is where you will need quite a detailed conversation with a geneticist to incorporate family history, lifestyle factors, and your genetic risk factor before we decide whether those ovaries could need to come out, basically. I'm going to focus a little bit on Lynch syndrome. I'm conscious we're kind of quickly running out of time. Lynch syndrome is a really interesting disorder. It used to be called hereditary non-polyposis colorectal cancer syndrome, which is a mouthful, and a name that isn't particularly accurate, because actually very little of that is appropriate apart from the hereditary bit, because we know it is an inherited condition. Non-polyposis bit, so most bowel cancer kind of starts from polyps, which are just growths in the bowel wall. And Lynch syndrome was kind of named to differentiate it from conditions that are associated with development of lots of polyps. But you can get polyps in Lynch syndrome, so calling it non-polyposis isn't really right. And actually calling it a colorectal cancer syndrome isn't really right either, because it's associated with all of these types of cancers, including cancer of the ovary. So Lynch syndrome can be caused by inherited problems in any one of a number of genes that I've listed there: MLH1, MSH2, MSH6, and more rarely a gene called EpCAM and another gene called PMS2. It's actually really common in the general population compared to other genetic conditions. So some people say the risk, in the general population, maybe as high as 1 in 121 people have this condition, 1 in 125, sorry. I probably think it's not that high, but it's certainly 1 in 270 at least. And about 95% of people that have this condition don't know they have it. So we're really bad for diagnosing it. Testing for Lynch syndrome can start in the tumour. Now, tumour-based testing for Lynch syndrome isn't actually routinely recommended in ovarian cancer yet. We're looking at it as part of a program or a big research study called the National Lynch Syndrome Project. But at the minute, we don't recommend tumour testing routinely on the NHS unless the hospital is participating in this program. But you'll have noticed that some of the genes associated with Lynch syndrome are now recommended as part of the hereditary gene testing for women that have the high-grade cancers. These are the risks associated with Lynch syndrome. So you can see the biggest risks are for cancer of the bowel. In the gynae setting, the biggest risk is actually cancer of the womb, but there is a significant risk of ovarian cancer, particularly if you have Lynch syndrome caused by alterations in MLH1, MSH2, and MSH6. And that's the rationale for including testing of those genes on that panel now for people that have ovarian cancer. When we think about ovarian cancer occurring within the context of Lynch syndrome, there are certain subtypes that are more common than others. So really the more common subtypes that happen here are things like endometrioid or clear cell cancers, compared to BRCA1 and BRCA2, where it's much more likely to be serous. Serous cancers actually are very rare within the context of Lynch syndrome, which is why we don't routinely really test for it outside of the endometrioid and clear cell subtypes. The age of diagnosis is younger than you would expect in the general population, but the good news is that the cancers associated with Lynch syndrome tend to be diagnosed earlier and tend to have better outcomes. And as I mentioned earlier, these type of cancers are much more likely to respond to immunotherapy if you can get access to it. When we talk about managing the risk of ovarian cancer in somebody with Lynch syndrome, risk-reducing surgery, again, is recommended from the age 35 to 40. This time you do need to take the womb because the womb cancer risk is increased in Lynch syndrome. At the minute, PMS2 related Lynch syndrome is not thought to be associated with an increased risk of ovarian cancer. So those people with the PMS2 related Lynch syndrome are managed slightly differently. In terms of family planning, I'm not going to labour this too much, but as I mentioned earlier, every child of somebody that has an inherited genetic issue has a 1 in 2 chance of being affected, and that can influence your decisions for family planning. Some people opt not to have children if they know they carry one of these things, which is obviously very sad, but that's their choice, absolutely. Some people opt to have children that are not related to them, so you might consider egg donation, embryo donation, or adoption. Some people just crack on and have kids naturally, and actually a lot of people, by the time you realise you have a genetic issue, you've already had your kids. And again, as I mentioned, we let them make their own decisions about testing when they reach adulthood. There are options for testing to minimise the risk of having a child that inherits something from you, and that can involve testing during pregnancy, which is called prenatal genetic testing, or testing before pregnancy, which is called pre-implantation genetic testing. So certainly if your known to carry a genetic risk factor for ovarian cancer and you have not yet started planning your family, it's definitely worth asking about these different options, because you know, depending on when you had your testing, you may not be aware of the changes that have developed in this space. Psychological considerations, I think, are sort of underrepresented in the literature, and I was so glad to hear Anna mention how supportive Overcome is, you know, in terms of providing support to people with cancer, and you know, that includes people that have cancer related to genetic changes. Peer support is absolutely invaluable. So if you know somebody else that has lived through the same experience as you, it can be so helpful. There are obviously information and support out there from medical teams, and I'd strongly recommend you look at the Royal Marsden Patient Information Library, because we've got lots of videos and leaflets about all of these kind of genetic conditions. Websites, be careful, because some websites are better than others. So I would, you know, the internet is very powerful, but it can also be a source of misinformation. So just be judicious in terms of what you look at, and try to go, you know, places that are endorsed either by Overcome or by hospitals or your doctor. So in summary, one size fits all is not appropriate when it comes to ovarian cancer, because there's so many differences depending on the type and depending on the genetic basis. Genetic testing should certainly be offered to everybody that has high-grade cancer. So if you haven't had any kind of discussion about it, make sure you ask your doctor. The cancer risks associated with these inherited things are not uniform, so it depends on the gene, the gender, the family history, etc. Risk reducing strategy, very much a personalized thing. Cancer treatment options very much influenced by the genetic basis, and similarly family history or family planning options need to be bespoke as well. So I'm very sorry, Anna, I ran way over time there compared to what I promised, but hopefully that was a useful overview. So I'm happy to take any questions if there are any in the, maybe I'll stop sharing.
Thank you ever so much, Terry. That was really informative and interesting, and also really clear about a very complex area. So thank you ever so much. So we will just have a few questions, but as Terry mentioned, time is short. So and she's very kindly offered to answer questions afterwards that we'll send her via email. So if we don't get to your question, then we will send it afterwards. We had some come in about low-grade ovarian cancer, Terry. So I'll just read that. Someone said, friends in the US with low-grade serous ovarian cancer can get their tumours genetically tested to get more tailored treatment that works. Is there a way we low graders can do this in the UK, please? I've already discovered I'm not BRCA1 or 2. And then some other questions that came in about low grade. Do my daughters need to be tested as I'm diagnosed with low grade serous carcinoma? How does the genetic testing offered to patients differ for low grade ovarian cancer? And my sister was diagnosed with low grade serous ovarian cancer. Should I be concerned about the genetic community?
Yeah, all very good questions. So low-grade serous cancer is much more likely to be related to genetic changes that happen by chance as the cancer is developing, particularly in a gene called KRAS. And there are certain targeted drugs looking at KRAS now, but they're not so frequently used in ovarian cancer. So in terms of NHS testing, that's not routinely available, but it's certainly worth asking your clinical team, because you may be able to have profiling as part of research studies, you know, to determine if you're eligible for certain trials involving KRAS targeted therapies. In terms of the familial risk, the kind of good news, if you can call it that, the risk of developing low-grade serous cancer if your sister was affected is actually still very small, because for the most part it isn't related to hereditary risk factors. So generally we don't recommend genetic testing for familial factors in people with low risk or low-grade serous cancer. But it's you know, I suspect tumor-based testing for that type of cancer will expand over time.
Thank you, Terry. And someone's asked, what further work is planned for examining gene mutations FOXL2 and DICER1 for granulosa cell tumor?
Very, very, very good question. And I just, in the interest of time, didn't have time to go into the non-epithelial. Hopefully I can come back at some stage and talk about the rarer cancers in a bit more detail. FOXL2 testing is not routinely undertaken for adult type granulosa cell tumors unless there's a question mark about the diagnosis. But certainly I have found that incredibly helpful, because some of our adult cell granulosa cell tumors, although the pathologist might be very convinced, if they don't have a FOXL2 mutation, you actually need to relook and make sure that it is an adult cell granulosa, or an adult type granulosa cell tumour, and not a juvenile type, because the juvenile type is much more related to hereditary risk factors, including in DICER1. So I have used tumour-based testing to try and figure out what type it is a lot, and then you may go on to recommend hereditary testing in that kind of context. At the minute, it's in the NHS directory. You can do that type of testing if there's a question mark about the diagnosis. So certainly if someone's diagnosed with a granulosa cell tumour at a very young age, I would be quick to do that test to make sure that it's the right diagnosis and to see if any further testing is needed. If it's a juvenile granulosa cell type tumour, they're entitled to DICER1 testing, or well, it should at least be considered for both hereditary and tumour-based changes.
Great, thank you very much. And let me see. Okay. This will be the last question, so thank you everybody, and we'll, as I say, we'll pass on the other ones. My daughter's considering preventative breast surgery. Did you say this is unlikely if we are BRCA1? As far as I know, no one in the family has had breast cancer.
Oh, I don't really understand that. Sorry, if she's been proven to have a BRCA1 alteration, she's got a very high risk of breast cancer. So risk reducing surgery would be an option, definitely, regardless of whether there's a family history of breast cancer. So yeah, but it's still a very personal decision. It's not the only option available to her. But yes, if it's definitely proven to be BRCA1 and she carries it, then yes, we would definitely consider it in that kind of context.
Thank you, Terry. Thank you for your time and all your expertise, and we really, really appreciate it. Alice, was there anything that you wanted to say before we finish?
No, I think it's just the difficulty at the minute is that these changes in the NHS kind of criteria for genetic testing have changed so rapidly, and actually the communication around it has not been fantastic. So sometimes it's just been very difficult for the oncologists to know what's out there. So if you haven't been offered it, I'm absolutely not criticizing the oncologists, because actually it has just been a bit of a higgledy-piggledy way of communicating the changes. So don't be afraid to ask your oncologist if you haven't had this yet, and just say to them, actually the NHS directory was updated in April 2022, you may not be aware. So I hope I didn't come across as being really critical. It's just such a rapidly moving area that it's actually been really tough for everybody to keep up with it.
Yeah, absolutely. Thank you very much, Dr. McVeigh.
And more than welcome. Thanks for the invitation. I hope everyone has a wonderful weekend. And as I said, I'll hopefully get to answer all your questions virtually.
Great.